Hello and welcome to the first installment of NATF's Patient Pulse, a new on-demand monthly educational webinar series. As many of you know, March is Blood Clot Awareness Month, and today's webinar will be focusing on one of the most common anticoagulants used to treat and prevent blood clots, warfarin, which also goes by the brand name Coumadin. We now have newer options to treat and prevent blood clots called direct oral anticoagulants, or DOACs. And patients commonly ask why the medical community continues to use warfarin when newer treatments are available. We're thrilled to welcome Dr. Elaine Hylek to explain the answer to this question. Dr. Hylek is a professor of medicine at the Boston University School of Medicine and the director of the Thrombosis and Anticoagulation Service at Boston Medical Center. She oversees a busy internal medicine practice at Boston Medical Center and is also an active researcher focusing on safe anticoagulation and stroke prevention in atrial fibrillation. Thank you for being with us today, Dr. Hylek. We'll turn it over to you.
Well, thank you so much, and what an honor really it is to speaking directly with patients, which is what I absolutely enjoy. So before we get started, all of our listeners should know that I definitely am very involved in many different trials, looking at various aspects of either venous thromboembolism or related to atrial fibrillation. I've had, some consulting opportunities, which I actually really enjoy. As well as working with the NHLBI, that's the National Heart, Lung, and Blood Institute, as well as writing some guidelines. So with that being said, let's just dive in. So where I want to begin today is to really look at the 2019 American Heart Association, American College of Cardiology, and the Heart Rhythm Society had a focused update just last year compared to 2014, the guidelines for the management of patients with atrial fibrillation. So much of what I'll be talking about in the next 15 minutes will be related probably more to atrial fibrillation, but when we think about the DOACs, and we certainly are using those for acute treatment of DVT and pulmonary embolism, as well as that longer-term anticoagulation for individuals at perhaps increased risk of a recurrence. But many of these themes would cut across all of these indications. So with that being said, let's just move to the next slide. So here what you have are the key distinctions, looking at the AF guideline in 2014 on your left, and the 2019 guideline on your right. And you can see that the NOACS, which some societies now prefer DOAC for direct oral anticoagulant, which they're the same, approved for stroke prevention, and you can see dabigatran, rivaroxaban, and they have added edoxaban in the 2019. What's new is really the second line, the oral anticoagulants recommended for eligible patients, and I'll stress eligible. And here in the 2014, it was really warfarin or the NOACs. And in 2019, they kind of, made the next step to say, hey, you know what? We're going to recommend these NOACs or DOACs over warfarin. And that's a class 1 indication. And I think as we go through this webinar today, we'll have a better understanding as to why that is the case. So with the next slide, and let's really emphasize this, again, this is for the atrial fibrillation community, that for patients with AFib, except moderate to severe mitral stenosis or a mechanical heart valve, who are unable to maintain a therapeutic INR level with warfarin, use of a NOAC is recommended. So on this slide, we're learning a few things, so that these DOAC medications are absolutely not approved for individuals who have moderate to severe mitral stenosis or have a mechanical heart valve. So that's the first, and those are truly contraindications for individuals with those two conditions. However, the other thing that we see here is that these three cardiology societies are saying, if you're able to maintain a therapeutic INR level, and what does that mean? Well, I would say, what would a physician say is therapeutic? I would say over 70%. Basically of the time that your INR is being checked, that 70% of the time that INR is going to be within that 2 to 3 range for atrial fibrillation. So if for some reason there's wide swings in your INRs, that sometimes they're 1.4, sometimes they're 3.8, and there's no real reason for it. Perhaps the diet hasn't been stable with a rich vitamin K, green leafy vegetables or things like that, you might consider, well, this is tough. For some reason, my liver or my diet isn't necessarily optimal with warfarin. And I think in that instance, clearly, it would be, makes more sense to me to be on a NOAC or DOAC. However, if that INR level is fluctuating all over the place because, it's sometimes we miss medicines, we for whatever reason, we forget them while we're traveling or whatever, because, remember with the NOACs and the DOACs, they have a very short half-life, meaning that when you take the tablet, how many hours does it take for half of that medicine to already be gone? That's what the half-life is. And with warfarin, and I know I'm probably talking too much, but with warfarin, it's 40 hours, and it can be 60 hours for individuals like over age 75 and 80. This is in stark contrast to the DOACs, where the half-life is about 8 hours. So there's going to be less forgiveness for not taking your medications with these new drugs because your body is metabolizing them very quickly. And that's one of the, I think one of the reasons that sometimes physicians think, well, maybe it's better to be a little bit enrolled and we're checking your levels and this type of thing. So, but again, this is all coming back to the therapeutic INR level is really, I think, one of the mainstays of someone remaining on warfarin, because to some degree they've demonstrated that, this medication is working within their biological organism. So I want to just share with people like why prosthetic valves. And we had a study called Realign that looked at dabigatran, and you can see on the left, that is a valve ring. And on the right of this picture, you can see this clot. And this is a very frightening and scary thing. And this is the reason that these new drugs are absolutely contraindicated in individuals who have a prosthetic heart valve, because we just were not able to demonstrate that these drugs were able to prevent the types of clot that form on these surfaces. But again, this is just for the individuals who have a mechanical heart valve. Recently, there is a new type of a valve surface made of carbon. It lacks the silicon, and I'm not going to really spend much time on this, just to say that there's a lot of research in material science and other scientific entities to try to get away from having to always use warfarin in this setting. And so we'll see what happens with this particular valve called the ON-X, O-N-X valve, to see if, we're able to use a DOAC like APIXABAN. But this is a huge question mark, and absolutely physicians will not be offering anything but warfarin for this patient population. So I want to share quickly this recent study just in the Journal of the American College of Cardiology just in 2019, sort of like looking at what happens if we actually try to use these medicines with individuals with mitral stenosis. Remembering that this is the other group of patients that right now the FDA has not approved, I'll emphasize, these DOAC drugs with mitral stenosis. But I want to share this because I think in certain parts of the world, this is important. So this is off-label use in South Korea. This is hypothesis generating, clearly needs more studies. But if you look at this flow chart as to how they designed this study, it's not a randomized trial. I want to emphasize that. This is not a randomized trial. So you're basically looking at their sort of Observational study is what this was. They looked at individuals who had mitral stenosis, almost 30,000. Look at the number that they excluded, patients who were not on an anticoagulant, almost 11,000 individuals in South Korea with mitral stenosis and atrial fibrillation who were not on an anticoagulant. And I think for me, this is a very troubling number of individuals because they are at such high risk of having a stroke with mitral stenosis and AFib. It just really, for me as a physician, really bothers me that this is happening. But if you look and see what they did, they enrolled about 7,300 individuals. And there's the anticoagulation with the DOAC, and then you have with the warfarin. And here you can see that they did what's called a propensity score matching. And what this accomplishes is they do their best to try to make these groups similar. So now if we look at the central illustration, this is striking because here we have the ischemic stroke risk, intracranial hemorrhage risk, all-cause death. And you would say, oh my gosh, warfarin, like what happened to warfarin? Like what is going on here? Is warfarin, does it really lack efficacy in this population? And this is the part that I really want to stress, that this study, if is the most amazing study that demonstrates how ineffective warfarin can be in clinical practice. So in South Korea, many of the physicians there choose lower INR targets, which I think is a big mistake that people make. So instead of the 2 to 3 range, they're going to pick a 1.5 to 2 range or a 1.5 to 2.5 range, and that is literally just not at all acceptable. And I think in addition to that, there's a lot of questions about adherence and compliance with warfarin. So that this is really, in my opinion, a comparison of DOAC compared to subtherapeutic warfarin because it was not a randomized trial. But again, around the world, if I had a family member, a friend living in South Korea, I certainly wouldn't want them to be given warfarin with a low INR range target or not to have an anticoagulation service that could help patients stay in range. So with that, let's just kind of move on to some other things that are really cross-cutting all indications. And one of these is the antiphospholipid syndrome. These are individuals that are at higher risk for DVT, PE, as well as an arterial embolism, which would be like a stroke and atrial fibrillation. And these agents are absolutely not to be used for anyone who's listening who's shown that they have these antibodies that are positive. So we have the lupus anticoagulant, an anticardiolipin, and what's called the beta-2 glycoprotein. So this would be sort of a thrombophilic, I would say, workup that we usually reserve for usually patients on the younger side who come in with a DVT, a PE, or some type of a stroke. Because if you meet the criteria for antiphospholipid syndrome, you can see that those that were studied, which was predominantly rivaroxaban, as well as now the Eliquis or APIXABAN label, clearly is showing, or the package insert is showing that, there's an increased rate of recurrent thrombotic events compared to the traditional vitamin K antagonist therapy, which would be your warfarin. So let's look at drug-drug interactions with the NOACS or DOAC. So let me first stress that the interactions that we see are far, far fewer than what we see with warfarin, and for a lot of different reasons. But still, I mean, your physician is going to be looking carefully to make sure that there isn't any, major drug interactions. And here you can see with the red boxes, these are really avoid use. So, there are still situations where you're not going to just leap to have a patient put on a NOAC or a DOAC because of these different interactions. Let's remember that how are these drugs metabolized? So dabigatran in that first column is completely metabolized by the kidney. Rivaroxaban and APIXABAN are really metabolized largely through the liver as well as the kidney. But what's important about these two medications is that they're metabolized through the liver, and you can see on the left side where it says a strong inducer of CYP3A4. The CYP3A4 is the way a lot of medicines are broken down. So that's where you get into this interference, because clearly with the DOAC, rivaroxaban and APIXABAN needing that particular enzyme to be broken down, if there's competition with other medicines that the patient is taking, you could really have elevation of levels of these blood thinners, and you clearly don't want that. So I'm not going to go into this table at length, but it's easy enough to check to see if any of your medicines are going to interfere with the metabolism of these drugs. You can really put it into Google or look at some of the package inserts, which is what I think is where you really get the information you should have at your fingertips as to whether or not it's safe or safest for an individual patient to be on one of these medicines. So oncology, I think this is another area where we still need more information. But in our patients who, are being treated for cancer, there are some drugs that really do interfere, like these tyrosine kinase inhibitors. You got paclitaxel. There's some hormonal agents. So your pharmacist and your oncologist, internal medicine doc, they're really going to be looking to make sure that these medicines are going to be okay for you if you're taking rivaroxaban or APIXABAN for atrial fibrillation or really a DVT or PE that occurs in the context of cancer. The other thing, and again, this was just published in 2020 in January, looking at the real world use of this combined PGP and moderate CYP3A4 inhibitors with rivaroxaban or APIXABAN. And again, I don't want to overemphasize this because I think these types of interactions with drugs and diet, we clearly see with warfarin. That's where we get a lot of the INR variability. And these drugs are actually, I think, much, much, much fewer. There's fewer drugs that inhibit these medications. But in this particular study, they looked at amiodarone, dronedarone, diltiazem, and verapamil. And it seemed that when these drugs were used in combination with rivaroxaban or APIXABAN, again, because they use that same liver enzyme, that there was an increased risk of bleeding. And so I think, again, this might be the reason that the prescriber is thinking, well, maybe it would be better to have the patient remain on warfarin just to be sure, because we can measure the INR and we'll make sure that there's no increase in the levels. So now let's just go to kidney function. And remember, I said that, unlike warfarin, which is completely metabolized through the liver, these medicines are really metabolized in somewhat. I guess dabigatran is predominantly cleared by the kidney by about 80%. Rivaroxaban is 36% roughly. Edoxaban is about 50% cleared by the kidney, and APIXABAN about 25% cleared by the kidney. But you can see this big red box around individuals that have what we call the filtration rate of the kidney that's less than 30. We really didn't study a lot of these individuals in these clinical trials. And if you're thinking, well, for medicines that are predominantly cleared by the kidney, like dabigatran, well, you're probably not certainly going to be using these drugs in individuals who have widely fluctuations, in their kidney function. And I think that that's another reason that patients may still be on warfarin, because again, it comes back to this comfort that we have, this level of confidence, because we can be monitoring the INR among our patients who have fluctuations in kidney function, certainly chronic kidney disease at this stage 4, and certainly on dialysis. I mean, we have I would say zero information on the safety of any of these drugs, although the FDA kind of gave a very cautious green light for the use of APIXABAN. But still, I would certainly say that right now we don't have any clear indication of safety or efficacy in this challenging population on dialysis. I think one of the biggest reasons that patients remain on warfarin is cost. And I literally just looked up some of the Medicare Part D. There's many pharmacy options that patients can purchase. But let's just look at these. I literally just like cut and pasted this. You can just go online and look at this for yourself. But I chose these because it shows to me that there's a wide variability in cost, and this is for a 30-day supply. I'm just going to pick on APIXABAN right now. So the average copay for a 30-day supply of APIXABAN, 5 milligrams, you can see $42, $194 per month, $56, $42, $27, and $467 per month. Many of our patients are on at least 9 prescription medications. So even a $27 looks like a real bargain. I don't know what all that particular plan covers or doesn't cover. But still, if you're on 9 meds, I mean, this is not a trivial matter. And look at the warfarin 30-day supply, $4, $2, $4, $2, $1, $6. So cost for patients is a very important reason that some individuals are saying, hey, I'm not going to come up with $190 a month if I can have warfarin, and basically it's going to cost me $2. So cost still remains a big issue for these medicines, and that may be one of the other reasons why an individual patient remains on warfarin. And then these are among my last few slides, but I want to look at, again, this is atrial fibrillation. And if you look at the very top, the ischemic stroke, what that says is, like, was there any superiority of these medicines when it came to ischemic stroke? And being involved in this field as much as I have been for 20 years, you know, I would say that when it comes to the ischemic strokes that occur in atrial fibrillation, these medicines did not demonstrate any real difference with warfarin. Now, the rare, but frightening and, you know, most feared complication of a blood thinner is actually bleeding in the brain. That's called a hemorrhagic stroke or bleeding stroke. And here, thank goodness this is a rare outcome. But here, this is where we really saw the benefit of these medications, with about a 50% reduction in that particular adverse event, which is an incredible breakthrough for these medicines. But we didn't get everything that we had hoped for with these medicines. And I want our patients to see the gastrointestinal bleeding, which for several of these medications, the dabigatran 150 dose, rivaroxaban, as well as the edoxaban, I believe that the bleeding from the gastrointestinal tract was actually a bit higher than what we see with warfarin, and I don't think this has been really fully understood. But again, I think this is just telling you that these haven't solved every single problem with what we see with our patients, so that the GI bleeding, which is quite a frequent thing that we see in our elderly patients, our oldest patients. So again, something just to keep in mind. There's another medication that's being studied now called a factor 11 inhibitor, which, you know, may show promise, but we haven't studied it yet outside of the orthopedic indication. So other knowledge gaps, things like what happens if you're on one of these medicines and you have a stroke, or you have like a breakthrough DVT or PE. Is that a reason that the doctor would put someone back on warfarin? We have no safety data that tells us that individuals who have some really, I would say, a moderate to severe, certainly moderate liver dysfunction, we don't know what to do with those patients. The short gut syndrome, which you can sometimes see associated with gastric bypass, this is another group. We did talk a little bit about active malignancy, not only with the interactions with chemotherapy, but there's also a concern with increased bleeding with GI cancers in these patients. So in this instance, we're still going to be using low molecular weight heparin, not warfarin even, but low molecular weight heparin during those periods of active treatment for DVT or PE. Extremes in weight, I mean, there was some concern about individuals with severe obesity, with body mass index over 40. And I would say, so far it doesn't look like that's a problem, but I'm going to say we still need more information there, as well as with the pregnancy. We haven't studied these agents at all among women who are currently pregnant. So I think with those knowledge gaps, I'm probably going to say thank you so much. And just to reassure our listeners that warfarin is still, it's a terrific anticoagulant. It's just difficult, and people don't like the blood test. They want to be freed of this need to constantly have their blood levels checked. But again, I think it comes down to making sure you don't meet any of these other criteria that we discussed, as well as certainly the cost can sometimes be an issue. The GI bleeding might be an issue. But clearly around the world, I mean, these agents have now been endorsed and are recommended over warfarin for all of the reasons that I just stated. So with that being said, I'm going to say thank you for listening, and I hope this was helpful. Bye-bye now.
Great. Thank you so much, Dr. Hylek, for that excellent overview. We really appreciate your time and expertise. And thank you all for listening. And you can tune in next month for another episode of The Patient Pulse.